Welcome to Pharmacology Outline channel. In this video, we will discuss the complications that occur when the liver reaches its final phase of chronic disease, namely cirrhosis. This is a visual progression of liver conditions, starting with a healthy liver, normal structure and function, moving to fatty liver. Excess fat builds up inside liver cells, then fibrosis, scar tissue forms due to sustained injury, and finally, cirrhosis. Extensive scarring, leading to liver dysfunction. Liver is the largest solid organ in the body. It is located in the right upper quadrant of the abdomen. It divided into lobes: larger right, smaller left, and minor caudate and quadrate lobes. Let's explain the blood supply of the liver. 30% of blood reaches the liver from the hepatic artery, which is oxygen-rich, while 70% is from the portal vein, that is nutrient-rich but oxygen-poor. So we can explain first-pass effect, as blood from the intestines flows to the liver first, allowing detoxification and nutrient processing before reaching general circulation. This diagram shows the dual blood supply of the liver, the hepatic artery and portal vein, and how they feed into the liver lobules, then drain via hepatic veins into the inferior vena cava. Here we see the microscopic anatomy of the liver. The liver is made up of structural units called lobules. Each lobule contains a central vein and is surrounded by portal triads, hepatic artery, portal vein, bile duct, forming a hexagonal arrangement. This layout is vital to the liver's function in filtering blood and producing bile. The portal triad refers to three key structures at each corner of a liver lobule. 1. The hepatic artery, which brings oxygenated blood. 2. The portal vein, delivering nutrient-rich blood from the gastrointestinal tract. 3. The bile duct, which carries bile produced by hepatocytes to the gallbladder and intestine. These triads work in concert to ensure the liver performs its filtering, detoxifying, and bile-producing roles. This slide gives a more detailed view of how the blood from the portal vein and hepatic artery flows through the sinusoids, tiny capillary-like channels, toward the central vein. This network enables efficient exchange between blood and hepatocytes. The schematic here shows a liver sinusoid, a special type of capillary that facilitates blood flow through the lobule. Blood from both the portal vein and hepatic artery flows through these sinusoids, passing between hepatocytes, the liver's primary cells. As this happens, nutrients are absorbed, toxins are removed, and bile is produced. You'll also see Kupffer cells, specialized macrophages that line the sinusoids. They play a key role in the immune defense of the liver, clearing bacteria and debris from the blood. Here, we explore the full anatomy of a liver lobule. It's hexagonal in shape. At each corner is a portal triad. Blood flows from the portal triads through the hepatic sinusoids toward the central vein. Hepatocytes are arranged in plates along these sinusoids, performing metabolic functions. Bile flows in the opposite direction, from the hepatocytes into tiny bile canaliculi, which ultimately drain into the bile ducts. This slide introduces the hepatic stellate cells, located in the space of Ducy, between hepatocytes and the endothelial cells lining sinusoids. In a healthy liver, these cells store vitamin A in lipid droplets, making them the largest vitamin A reservoir in the body. When the liver is injured due to toxins or viruses, stellate cells get activated. They transform into myofibroblast-like cells, which produce extracellular matrix proteins. While this scar formation is protective initially, chronic activation leads to fibrosis, the hallmark of long-term liver damage. The liver is one of the most versatile organs in the human body. Its functions include metabolism of carbohydrates, fats, and proteins, detoxification of drugs, alcohol, and toxins. Storage of vitamins and minerals, like A, D, E, K, and B12. Synthesis of essential proteins, such as albumin and clotting factors. Bile production, which aids in digestion and fat absorption. Any impairment of these processes due to liver damage can have widespread consequences across the body. With the foundation laid, we now turn our attention to the complications that arise when the liver undergoes irreversible damage, leading to what we call end-stage liver disease, or cirrhosis. Liver disease occurs along a continuum. Acute injury might result from a viral infection or drug toxicity. Chronic injury develops over time, commonly from hepatitis viruses, alcohol abuse, autoimmune disorders, or genetic conditions. When the liver is repeatedly injured, it tries to repair itself. This results in scar tissue forming called fibrosis. Eventually, if the damage persists, the liver's structure and function become permanently distorted. That's cirrhosis, the irreversible stage. Here we see a cirrhotic liver. Note the nodular surface, a result of scar tissue forming regenerative nodules. This reflects extensive architectural distortion, leading to compromised liver function and blood flow. Cirrhosis is not just scar tissue, it's a complex remodeling of the liver that affects everything from bile drainage to detoxification. Blood flow is disrupted, causing increased pressure in the portal vein and affecting other organs. This slide may show a pathological or histological representation of cirrhosis or liver fibrosis. It helps reinforce the structural damage we've discussed, showing fibrotic bands, regenerative nodules, and disrupted architecture. We might be seeing a zoomed-in or differently stained view here, providing further clarity on how cirrhosis disrupts normal liver tissue. The purple areas likely represent fibrotic tissue, while clusters of liver cells appear as nodules. Hepatic cirrhosis is the final common pathway of many chronic liver diseases. It's marked by ongoing liver damage, where normal tissue is gradually replaced by fibrous scar tissue and regenerative nodules. Some individuals may not show symptoms until complications develop. Globally, the most common causes are chronic hepatitis B or C infection, chronic alcohol abuse. Over time, the liver's ability to perform vital functions, like protein synthesis, detoxification, and bile production, declines significantly. One of the most well-understood causes of cirrhosis is alcohol-related liver disease. Let's follow its progression. First, fatty liver, steatosis, the earliest stage, where fat builds up in hepatocytes. Second, steatohepatitis. Fat accumulation triggers inflammation and hepatocyte injury. Third, fibrosis. As liver cells die, the body attempts to repair damage, creating scar tissue. Finally, cirrhosis. Prolonged inflammation and fibrosis permanently alter liver structure. Alcohol metabolism produces acetaldehyde, a toxic byproduct that causes oxidative stress damaging cellular structures and promoting fibrosis. In this slide, we dive deeper into the biochemical process. Ethanol is metabolized in the liver by alcohol dehydrogenase. This produces acetaldehyde, a highly reactive and toxic compound. Acetaldehyde triggers inflammation and stimulates collagen deposition, leading to fibrosis. The damage is further worsened by oxidative stress, which overwhelms the liver's antioxidant defenses, accelerating injury. Here, we may see a diagram of alcohol metabolism pathways illustrating the transformation of ethanol into acetaldehyde and eventually into acetate, with byproducts like NADH that disrupt metabolic balance. This visual could show microscopic liver changes such as ballooning degeneration of hepatocytes, Mallory bodies, and neutrophilic infiltration, typical of alcoholic hepatitis. With chronic use, this progresses to cirrhosis, where the liver becomes hard, nodular, and shrunken. Another major cause of cirrhosis worldwide is chronic infection with the hepatitis C virus, HHCV. Not every person infected with HCV develops cirrhosis, so progression depends on multiple factors. Immune response. A stronger immune attack can lead to more inflammation and scarring. Age at infection. Older age is associated with faster fibrosis progression. Sex. Males tend to have faster progression than females. HCV genotype. Certain strains may be more aggressive. Hepatic iron levels. Iron overload can worsen oxidative stress and liver damage. These factors act together to determine whether HCV infection progresses to cirrhosis. Although the exact mechanisms of liver damage in HCV are not fully understood, several theories exist. Direct cytotoxicity by viral proteins. Immune-mediated injury, where the body's attempt to kill infected cells causes collateral damage. Chronic inflammation, stimulating stellate cell activation and fibrosis. The virus does not kill liver cells directly instead. It's the immune system's persistent attack and the body's repair response that gradually leads to cirrhosis. This image could show the virus infecting hepatocytes, immune cells responding, stellate cells becoming activated, fibrotic matrix formation. It's a cascade of injury and repair that, over time, permanently scars the liver. Beyond alcohol and hepatitis, cirrhosis can result from several less common but important causes. Primary biliary cirrhosis, an autoimmune disease where the body attacks bile ducts. Bile builds up, causing inflammation and scarring. Wilson disease, a genetic disorder where copper isn't excreted properly. Copper builds up in the liver, damaging cells. Other genetic disorders and storage diseases can also result in cirrhosis. Each of these conditions has a unique pathogenesis, but they all lead to chronic inflammation, fibrosis, and architectural distortion of the liver. Regardless of the root cause, the endpoint remains the same: irreversible scarring and compromised liver function. Cirrhosis may be diagnosed even before symptoms appear, often during imaging for unrelated issues. But, in many cases, patients present with decompensated disease, showing complications like ascites, variceal bleeding, or hepatic encephalopathy. Although liver biopsy remains the gold standard, it's invasive and often replaced by non-invasive tools like ultrasound CT scans, FibroScan. Additionally, clinicians use the MELD score, a critical tool, to assess disease severity and prioritize patients for liver transplant. When evaluating liver disease, we rely on blood tests. AST and ALT indicate hepatocyte damage. Alkaline phosphatase, often elevated in biliary obstruction or injury. These are actually liver injury tests, not true indicators of liver function. A normal ALT-AST does not mean the liver is functioning well. It only means there's no acute injury. Other blood tests give clues to functional capacity. Gamma-glutamyl transpeptidase, marker of bile duct involvement. Bilirubin, reflects the liver's ability to process waste. Albumin, produced by the liver. Low levels suggest poor synthetic function. Clotting factors, factor 5, 8, and prothrombin time. Prolonged times suggest impaired production and thus worse liver function. Let's now look at the MELD score formula, which uses creatinine, reflects kidney function. Bilirubin indicates liver's ability to eliminate waste. INR reflects blood clotting ability. The formula uses natural logarithms of these values to generate a score from 6 to 40. Higher scores indicate more severe disease and higher 3-month mortality risk. This score is vital in liver transplant prioritization. This slide may show example MELD scores and corresponding mortality risks, MELD 10 to 19. Low risk, MELD 20 to 29. Moderate risk, MELD 30 plus. High risk, often prioritized for transplantation. Regular monitoring of MELD is essential in managing advanced liver disease. One of the major consequences of cirrhosis is portal hypertension, which refers to increased blood pressure within the portal venous system, the major vein carrying blood from the digestive organs to the liver. Scar tissue from cirrhosis blocks normal blood flow through the liver, forcing blood to seek alternative routes. This creates back pressure and leads to many complications. The liver receives blood from the digestive organs via the portal vein. In cirrhosis, fibrosis compresses these blood vessels. As a result, portal pressure increases, forcing blood to find alternative pathways through smaller, more fragile veins, setting the stage for variceal bleeding and ascites. These diagrams likely illustrate normal versus obstructed blood flow through the liver, collateral circulation forming due to the blockage, consequences like splenomegaly, varices, and ascites. You can also expect arrows showing redirected blood flow toward low-pressure veins. Why does portal hypertension happen? Inside the liver, fibrosis and nodules distort architecture and compress sinusoids. Vasoconstriction increases due to reduced nitric oxide. Outside the liver, splanchnic vasodilation causes more blood to flow into the portal system, so both increased resistance and increased inflow lead to dangerously high portal pressure. The most common clinical manifestation of cirrhosis is ascites, fluid buildup in the abdominal cavity. Portal hypertension increases pressure in the portal vein. This pressure causes fluid to leak from liver sinusoids into the peritoneal cavity. Ascites can cause abdominal distension, discomfort, and risk of infection. This slide likely shows a patient with massive abdominal distension due to ascites, or a medical procedure called paracentesis, used to remove excess fluid. Let's examine how ascites forms. First, the portal hypertension causes splanchnic vasodilation and increased nitric oxide production. The resulting vasodilation lowers arterial blood pressure. To compensate, the body activates renin-angiotensin-aldosterone system, antidiuretic hormone, sympathetic nervous system. These responses cause sodium and water retention, leading to fluid accumulation. So, ascites is not just passive leakage. It's a result of complex systemic changes. Beyond the hormonal and pressure changes, other factors contribute to ascites. When the lymphatic system can't drain fluid fast enough, excess accumulates. Low albumin, due to impaired liver synthesis, reduces oncotic pressure and allows fluid to leak into the abdomen. The main goals of treatment are addressing the cause. For example, stop alcohol in alcoholic liver disease, removing the acidic fluid using diuretics and sodium restriction, improving patient comfort, e.g., relieve abdominal pressure, preventing infections like spontaneous bacterial peritonitis. Most cirrhotic patients with ascites have high aldosterone levels, which promote sodium and water retention. The preferred initial treatment is spironolactone, which blocks aldosterone. It helps kidneys excrete sodium and retain potassium. Works best when paired with sodium restriction. If further fluid removal is needed, furosemide, a loop diuretic, is added. It increases diuresis and balances potassium, minimizing the risk of hyperkalemia from spironolactone. Options listed: triamterene, amiloride, potassium-sparing, used if spironolactone causes side effects like gynecomastia. Eplerenone, more selective aldosterone blocker, less hormonal side effects. Use limited due to cost and lack of data. When patients don't respond to diuretics or fluid keeps building up, we call it refractory ascites. The standard treatment is large-volume paracentesis. A needle is inserted into the abdomen to drain several liters of fluid. To prevent circulatory collapse, intravenous albumin is given at the same time. Paracentesis is safe, effective, and greatly improves quality of life in patients with severe ascites. Esophageal varices are swollen veins in the lining of the lower esophagus or upper stomach. As cirrhosis blocks normal blood flow, pressure in the portal vein rises. To compensate, blood diverts to nearby small veins, especially those in the esophagus. These veins aren't built to handle high volume or pressure, so they become enlarged and can rupture, leading to life-threatening bleeding. This image likely shows dilated varices along the esophagus. If ruptured, they cause massive gastrointestinal bleeding, presenting as vomiting blood, hematemesis, or black tarry stools, melena. When a patient presents with active variceal bleeding, it's a medical emergency. The top priority is stabilization. Start IV fluids and blood transfusion if needed. Insert an NG tube to decompress the stomach. Perform lavage to reduce aspiration risk. Simultaneously, begin medications and consider endoscopic intervention. To reduce bleeding, we use drugs that constrict blood vessels and lower portal pressure. Vasopressin mimics a natural hormone that tightens blood vessels. However, it can cause serious side effects like abdominal cramps, irregular heartbeat, or even tissue death. Because of this, vasopressin has largely been replaced by octreotide, a synthetic form of somatostatin. Octreotide decreases splanchnic blood flow, reduces portal pressure, has fewer adverse effects. If vasopressin is used, it must be given as a continuous IV infusion due to a short half-life. A central line is recommended to avoid tissue damage if it leaks outside the vein. Nitroglycerin is often co-administered to counteract vasopressin's side effects. On the other hand, octreotide is safer and easier to administer. It's now the first-line drug for managing acute variceal bleeding. Terlipressin is another vasopressin-like drug used in many countries, but not available in the U.S. It has a longer duration of action and fewer cardiovascular side effects. Clinical studies show it can control bleeding in about 80% of patients with esophageal varices, making it a valuable option where available. Once varices are identified, even if they haven't bled, yet primary prevention becomes critical. The goal is to reduce the risk of a first bleeding episode, which carries a high mortality rate. The most effective first-line therapy is non-selective beta blockers, such as propranolol, nadolol. These drugs work by beta-1 blockade, reducing cardiac output, beta-2 blockade, causing vasoconstriction in splanchnic circulation, reducing blood flow to the portal system. The result? Lower portal pressure and reduced bleeding risk. When a patient has already bled, we move to secondary prophylaxis to prevent recurrent hemorrhage, which is very common. A key principle: do not start beta blockers during active bleeding. These drugs block the body's natural tachycardia response to blood loss. This can worsen hypotension and endanger survival. Instead, initiate non-selective beta blockers only after the patient has stabilized. Many studies confirm their role in reducing rebleeding risk and improving survival. Another cornerstone of secondary prevention is endoscopic therapy, especially endoscopic variceal ligation, also known as banding. This procedure involves using an endoscope to place rubber bands around varices, causing them to collapse and scar shut. Endoscopic variceal ligation is effective, safe, and can completely eradicate varices with repeated sessions. It is typically used alone in patients who can't tolerate beta blockers, or in combination with non-selective beta blockers for best outcomes. Hepatic encephalopathy is a neurological complication of liver failure. It happens when the liver can't remove toxins from the blood, allowing substances like ammonia to reach the brain. Signs and symptoms progress through stages. Early, personality changes, irritability, poor concentration. Middle, confusion, disorientation, sleep disturbances. Late, asterixis, lethargy, eventually coma. A distinctive smell from the breath, fetor hepaticus, may also be present due to volatile compounds in circulation. The exact mechanism behind hepatic encephalopathy is multifactorial. Ammonia is the most widely studied toxin. It comes from gut bacteria breaking down protein. Normally, the liver converts ammonia into urea, but in liver failure, ammonia builds up and crosses the blood-brain barrier. It causes astrocyte swelling, disrupting brain signaling. Other contributing factors: imbalance in amino acids, for example, low branched chain amino acids. Increased inhibitory neurotransmitters like GABA. The brain becomes poisoned by substances that the healthy liver would normally detoxify. The cornerstone of treatment is reducing ammonia in the gut. Lactulose is the first-line therapy. It's a synthetic sugar broken down in the colon. The resulting acids lower the pH, converting ammonia to ammonium, which can't be absorbed. It also acts as a laxative, flushing out ammonia-producing bacteria and undigested protein. Lactulose is effective for both acute and chronic encephalopathy. In comatose or non-cooperative patients, oral lactulose may not be possible. Alternatives: administer via nasogastric tube or as a rectal enema. Caution: do not overuse lactulose. Excessive diarrhea can cause dehydration and hypokalemia, which ironically worsen encephalopathy. The goal is 2 to 3 soft stools per day, not profuse diarrhea. For patients who don't respond well to lactulose or need combination therapy, we add rifaximin, a poorly absorbed antibiotic that targets ammonia-producing bacteria. It's well tolerated and reduces recurrence of hepatic encephalopathy. Neomycin, another option, especially via rectal enema. But chronic use risks hearing loss and kidney damage. Flumazenil, a benzodiazepine antagonist, has been studied because the brain in hepatic encephalopathy may have excess GABA-like activity. It can offer brief improvement, but it's not a long-term solution. To summarize, hepatic encephalopathy is a reversible but dangerous complication of cirrhosis. Treatment is aimed at lowering ammonia levels, avoiding precipitating factors like GI bleeding, infection, constipation, and sedatives. The mainstays of therapy are lactulose and rifaximin, with supportive care and monitoring of fluid electrolyte balance. Pruritus, or chronic itching, is a common and frustrating symptom for patients with liver disease, especially cholestatic conditions, where bile flow is reduced or obstructed. It tends to be most severe at night, can involve the palms, soles, or entire body. The underlying cause is likely the accumulation of bile acids and other pruritogens in the skin. Although not dangerous, it can be debilitating and significantly affect sleep, mood, and mental health. This slide likely outlines the treatment algorithm for pruritus in liver disease. Start with bile acid sequestrants. Consider rifampicin or opioid antagonists if needed. Use topical treatments or antihistamines for additional relief. The first-line therapy for cholestatic pruritus is bile acid sequestrants. Cholestyramine and cholestyramine bind bile acids in the gut and prevent them from being reabsorbed. These drugs are not absorbed and act locally in the intestine. However, they can bind other medications, so it's important to time their administration carefully. Take other medications 1 hour before or 4 to 6 hours after the bile binder. These agents can be very effective, but may cause bloating, constipation, and poor palatability. When bile acid sequestrants fail, we turn to second-line options. Rifampicin, an antibiotic that also induces liver enzymes, potentially increasing bile excretion. However, it can cause hepatotoxicity and drug interactions. Opioid antagonists like naltrexone, based on the theory that endogenous opioids in the brain contribute to itching. Topical agents like menthol cream or calamine lotion can offer symptomatic relief. While antihistamines are often prescribed, they are usually ineffective in cholestatic pruritus unless used for their sedative properties to help with sleep. Thank you for watching. If you enjoyed the video, please like and subscribe for more pharmacology insights. Hit the bell to stay updated. Keep learning.